up next, I want to introduce Dr. Shergill. She's with the University of Chicago, and she is a skilled oncologist who specializes in providing comprehensive care to patients with all stages of gastrointestinal and lung cancers, with an expertise in treating colon, rectal, and appendiceal cancers. She's currently developing novel therapies so she can offer her patients innovative clinical trials. And she's an executive officer for experimental therapeutic trials at Alliance for Clinical Trials in Oncology. And so I thank you, Dr. Shergill, for joining us today. I want to let the panelists and attendees know that we are skipping over the 5-minute break today, just to keep things on track. So stay tuned, and we'll have a break coming up soon. Thanks.
Oh, I'm sorry, just having some delay at my end. I am going to share my screen. I apologize, again, having just a little bit of tech issues. Okay, so hello everyone, thank you for bearing with me for that. Hope you're having a good conference so far. It is my honor to speak today at the symposium. My topic is to talk about systemic therapies for the treatment of appendix cancers. These are my disclosures. And the objective of my talk is to go over some of the treatment options and how I make decisions for patients for appendix cancers currently, and then future possibilities. So as has been discussed multiple times in other talks today, appendix cancer is very rare. The incidence is about 6 patients per million population. Often the presentation is that of abdominal pain, and patient gets imaging and then a surgery. And then either in the surgical specimen or at the time of the surgery, the cancer is identified. Prognosis for patients with appendix cancer actually really depends on the type of subcancer they have and the grade of the tumor. Prognosis can range from 10 to 90%. These are the 5 subtypes of appendix cancers. Another talk will go over this in much more detail, but I just wanted to mention them because I take all of this into consideration as I'm making decisions for patients for therapy, especially chemotherapy. There's mucinous appendix cancers, goblet cell cancer, colonic type non-mucinous adenocarcinomas, the signet ring cell adenocarcinomas, and that is the focus of my talk today. There's also the neuroendocrine non-epithelial tumors as a subtype of appendix cancer, which I won't be discussing in this talk. Appendix cancers have a really high propensity to metastasize to the peritoneum. So they're especially amenable to regional therapies like cytoreductive therapies and the HIPEC chemotherapy approach. The penetration of HIPEC, though, is only about 2 to 5 millimeters into the tumor. So HIPEC is not the primary way we give chemotherapy for the treatment of this cancer. And metastases outside of the peritoneal cavity is rare, although it can happen, and we have seen cases like that. What things do I consider as I'm making decisions of how to offer treatment for a patient? We look at patient-related factors like comorbidities. What are some other medical problems they have, the medicines they're on, and how would my treatment implement any changes in those? Symptoms, both from disease and from other conditions, and something called performance status, which is how a patient spends most of their day. Are they up and about, or are they in bed because of their disease or other medical problems, to see how they would benefit. And this has shown if we carefully pick therapies based on these factors, patients do better with those therapies than one therapy for all. So it's not one size fits all. And I also look at tumor-related factors, the type of cancer, plan for surgery, whether the patient is a surgical candidate or not, whether the tumor can be resected completely or not. And then very important is the grade of the cancer, low grade or higher grades like grade 2 or 3. This is showing, this is for mucinous appendix tumors, grade 1. generally tends to have a higher overall survival than grade 2 or grade 3 cancers. But in grade 1 tumors like LMAN, the role of chemotherapy is limited. Generally, it's accepted that chemotherapy is not needed for grade 1 or low grade tumors. In this study, we're showing that it actually did not benefit patients if they received chemotherapy or they did not receive chemotherapy. There are some other predictors of success for those patients, things like comorbidities, as I mentioned, age of the patient. So younger ages tended to do better, females tended to do better, and then use of chemotherapy did not correlate with outcome. However, surgery did. So in lower grade tumors in LMAN, we do not use chemotherapy. However, in higher grade, like grade 2 or 3 tumors, chemotherapy is used. These are data looking at the use of chemotherapy before surgery. So there is a plan for surgery for that patient. Well, when do we give chemotherapy? Actually, the graph on the left shows that patients, whether they got chemotherapy before their surgery or after, did not make a difference. However, patients who got before and had a response, like a histologic response, did much better as far as overall survival was concerned compared to those who did not have a response. So how do we use these data? We offer chemotherapy to patients upfront, and then we do assessments as time goes on during the course of their treatment to see if they're responding or if they're not responding. We use imaging, we use tumor markers, and we sometimes go take a laparoscopic look to see what kind of response the patients had to make then the decision of when is the appropriate timing for surgery. And then typically we would do chemotherapy after as well, depending on how much chemotherapy a patient received upfront. In patients who have unresectable disease, chemotherapy definitely has a role. This is in higher grade, again, grade 2 and grade 3. The overall survival at 3 years was about 60% for patients who received chemotherapy. Graph on the right shows that patients who received chemo, but then also got intraperitoneal chemotherapy did better. So the combination 3-year survival was about 73% compared to 50%. And we practice that. This is the trial that was mentioned in one of the other talks today, where we do iterative HIPEC. We do 3 cycles of HIPEC for patients, even if they don't have resectable disease, in addition to their systemic chemotherapy, to provide the best benefit to them. We have to carefully select those patients to make sure that those patients would benefit from this approach and can tolerate it. Goblet cell adenocarcinoma, I wanted to show this study over here to see patients who have undergone resection completely, who could benefit from adjuvant chemotherapy. And in this study, this is a recent study, they looked at multiple factors, including lymphovascular invasion, number of lymph nodes, margins, and all of that. Certainly margin negative disease was better, but the predictive factor from benefit from chemotherapy was lymph node positive disease. So if patient has goblet cell adenocarcinoma and has lymph node positive disease, we definitely offer chemotherapy in the adjuvant setting after the surgery. However, we have to keep in mind that this was a retrospective study. It was based on the NCDB database, and that does have limitations. So even in patients who have lymph node positive disease or negative disease, but I'm concerned, I would offer chemotherapy in that setting. As far as choice of therapy is concerned for patients, 5-FU or capecitabine makes the backbone of chemotherapy for all appendix cancer treatments, at least upfront. This can be combined with leucovorin. Leucovorin doesn't have an effect on treatment on the cancer itself. However, it can help make 5-FU, especially in the bolus form, more effective by helping it penetrate into the cancer cells. 5-FU or Capox or capecitabine can be combined with oxaliplatin. Those regimens are called FOLFOX or Capox. 5-FU can also be combined with irinotecan. That regimen is called FOLFIRI. I usually do not use capecitabine with irinotecan. I find that it's very, very toxic. So if I'm giving irinotecan, I like to do it with the 5-FU, which is the infusion. And then we can use 3 drug regimens as well, like 5-FU, oxaliplatin, and irinotecan, which actually is our preferred regimen at University of Chicago for patients who are able to tolerate. The more chemos I add, the more the toxicity. So again, careful patient selection is needed here. And then bevacizumab, it is an antibody which binds to the something called VEGF receptors, which helps blood vessels grow to the tumor. So the antibody binds to that and stops the growth of these blood vessels to the tumor. But bevacizumab has shown to improve survival in lower GI cancers. However, it does have side effects of bleeding, poor wound healing, as well as clotting. So patients who are going for surgery, my approach is to hold it at least 4 to 6 weeks prior to their surgical planned procedure to give them, to minimize that risk. And then if patients have progressed on these treatments and are still needing more therapy, our current standard of care is regorafenib and Lonsurf in those settings. But I think there's a lot of challenges as a medical oncologist managing appendix cancers. There's lack of well-controlled studies and data to guide the management. There is difficulty in measuring the disease, whether it's by imaging or tumor markers. Tumor markers are not always positive for appendix cancer. In addition, I think novel therapies are needed and novel ways are needed to help us measure the disease, to help generate those data so we feel we're giving our patients the best therapies. For these reasons, as has been mentioned previously, I think getting at least an opinion from a high volume center and perhaps getting treated at a high volume center is very important, not only for the skill of the surgeon or the medical oncologist, but also to benefit from the experience of the radiation oncologist, the radiologist, and the pathologist, and have an opportunity to participate in research. Participation in research may not help that patient, but it will help contribute to the knowledge in the field and help future patients. These are some of the unanswered questions that I think of. Is more chemo better? What is the appropriate regimen that I start a patient with, and how do I sequence that therapy? And what about targeting therapy? How about personalizing therapy for appendix cancers for patients? Is there really a role of radiation or immunotherapies in appendix cancers, as we are seeing more and more in some of the other cancers? And then how do we measure and monitor the disease better? Some of the ways we use is by molecular profiling. What does that mean? So what we do is take the DNA of the tumors. We take the tumor, we sequence out the DNA, and then we look at what mutations there are. All tumors have mutations. We are looking for mutations that can help us understand the tumor, meaning this is the mutations that's making mutations that's making the tumor grow. And is there an intervention available to help stop that process? This can be done on the tumor itself, so a biopsy or a surgical specimen. And there's also the liquid biopsy, which what does that mean? When patients have tumors, some DNA is shed into the circulation, and that DNA then gets picked up by these assays and sequenced out. One of the challenges with liquid biopsy in appendix cancer is the shedding may not be as much because they're contained in the peritoneum. And so if a test is positive with the liquid biopsy, that helps us. But if a test is negative, we always wonder if it's because we didn't have enough shedding of the DNA to pick that up in the liquid biopsy. I'm borrowing this from colon cancer data. So colon cancers are different than appendix cancers, but I wanted to mention how we are personalizing therapies in colon cancer and how we can open this avenue up for appendix cancer treatments. These are some of the subtypes of colon cancers that actually are in clinical practice currently. Who can benefit from immunotherapy? We do some of the testing to see these are the patients we can identify and they will benefit from immunotherapy. Some targeted therapy like targeting BRAF or HER2. There is new targets with KRAS G12C. We identify these personalized approaches for patients, and we have medicines that we can give to patients, and we know that they would benefit from it. We have evidence that they would benefit from it. These are looking at the appendix cancer sequencing. So this column over here is the appendix cancer sequencing. In this paper, they sequenced out 183 appendiceal adenocarcinomas, and they actually compared the mutations to colon cancer, both right and left-sided. And there are differences. So BRAF mutations are way more common in right-sided colon cancers as compared to appendiceal or left-sided cancers. APC mutations are way more common in all colon cancers and very infrequent in appendiceal cancers. And then KRAS mutations are quite common in appendiceal cancers and little less so in colorectal cancers, both right and left-sided. I think this shows us definitely that appendix cancers are not colon cancers. Appendix cancers are distinct from colon cancers, and that therapies and investigations have to be personalized to appendix cancers rather than some of the approach of extending those data to appendix cancers. And again, highlighting the need for investigation and research in appendix cancers. how can we use those data from molecular studies? I wanted to highlight some of the initiatives here. So as was mentioned, I'm involved in Alliance for Clinical Trials in Oncology, which is one of the NCI's cooperative groups. NCI had a study called the MATCH, where they identified mutations, and if there was a drug available for that mutation, regardless of the tumor type, a patient could go onto the study and see if the drug would benefit. This was a signal finding study for all those mutations. The next initiative to that is called the Combo MATCH. It is combination based on a biomarker. So if there is a mutation, can there be two medicines that we can combine that would help target that mutation better? Or can we combine it with chemotherapy and see if we can target that mutation better? I'm quite involved in that, both for operations as well as the scientific end of things. And we anticipate that we're going to be able to open the first 9 or so studies by spring or early summertime next year. This is one of the ones I'm involved with. This is looking at KRAS mutated tumors, and there are different cohorts to it. Cohort 1 and 2 are for ovarian cancers. Cohort 3 is for pancreatic cancers, and then cohort 4 is tumor agnostic, which is where I anticipate I would be able to offer therapies to my appendix cancer patients under that cohort 4. The reason pancreas is on its own is because about 95% of pancreatic cancers are KRAS mutated, so we did not want the whole cohort to be filled by pancreatic cancer patients just to get it to see what kind of signals we're getting in other tumors. These are signal finding studies, but hopefully would be available very soon to our patients. Then I wanted to kind of go over a few more studies that are going on in other cancers and seeing what we can borrow from that for appendix cancers. This one is looking at immunotherapy. It's a vaccine against KRAS mutations and use of immunotherapy with that to see if we can get responses in patients. These data were reported earlier this year, just actually last month. It's a small subset that was reported, about 12 patients, and it showed that patients did have a response with this kind of approach. And I think there was another key finding here, which is looking at which patients had a response. They did, in this study, they did liquid biopsy panel, and they followed the mutation. So not just whether the patient has a mutation, but how much. And then is it decreasing? Is that allele frequency decreasing with treatment? And for patients who the allele frequency was decreasing, actually had a survival benefit compared to those it wasn't. So it was a good way to see how we can monitor the patients who are responding to our therapies, maybe even early on. This is not in practice currently. This is, a very early study, early results, but there is more being developed by that same approach in other cancers as well as in lower GI cancers. Next couple of slides are use of immunotherapy and TKI therapy, a targeted therapy for patients in lower GI cancers. Again, very small subset of patients, only 32 patients that have been reported, but there is a larger study ongoing currently, and we await the results to see if this kind of approach could be beneficial and maybe even new standard of care for patients if it does in fact show a response and improve outcomes for patients. This is the pembrolizumab study. This is pembrolizumab compared to either regorafenib or Lonsurf for patients, which would be the standard third-line treatment after chemotherapy. We had this study open. It's actually getting closed pretty soon at the end of this month. But the next one we will be opening soon, it's not open currently, is use of 2 different kinds of immunotherapy agents in lower GI cancers to see if they benefit. This study is only for colon cancer patients, but certainly, hopefully, we can use these approaches for appendix patients in the near future if there are signals. And KRAS G12C targeting, I think I mentioned that briefly. Here, this codebreak study was also reported at ESMO this last month, so just in September, where KRAS G12C inhibitors that target one specific type of KRAS mutation were combined with EGFR therapy, something called cetuximab or panitumumab, and there was a response seen. The response was not seen just with the KRAS inhibitor. And so this shows that in, and in other cancers, like in lung cancer, they did see a response with just the inhibitor. So one, it shows us that every cancer may be different. We can combine what we know from the tissue of origin and what we know from targeted therapies and come up with the best therapy options for our patients. The bigger trial for this is ongoing currently, and it is open at our institution. So we will see, hopefully that big trial also shows a lot of responses. And then the last couple of slides I have are looking at the ctDNA, which is the test I had mentioned previously. Here, what they do is that they measure out the amount of DNA that a patient has circulating in the blood. Then there is a proprietary way to identify that this DNA is only coming from tumor and not coming from any other source from that patient. And then not just it's there, but also it's there and how much of it is there. And then you measure it after surgery at multiple time points. And if it's 0, that's meaningful. If it's going up, that's meaningful. And how fast is it going up? All of that is meaningful. And again, research is going on in that field to understand, exactly what those numbers are. This particular study looked at longitudinal ctDNA measurement as well as the CEA. And it shows that CEA is something that predicts, so as CEA rises, we can tell that the patient would have recurrence. But the ctDNA measurement outperformed the CEA, so maybe a little bit better test. Same study looked at CT scan findings as well. So each green dot here represents a patient, and when their CT scan was positive compared to the ctDNA was positive, and many of the patients have the lines going upwards from the green to the blue, which show that the ctDNA was positive before the CT scan was positive. This was a European study. The lead time here was about 8 months. The scanning frequency in Europe is different than what we do in the United States. So our lead time, if we did the study here, may not be 8 months, maybe less than that. But it still shows that ctDNA and this kind of novel technique can pick up disease in a hard to measure cancer early on compared to just measuring tumor markers or CT scans. Again, caution here because appendix cancers may not be shedding as much DNA. So if it's negative, that does not mean that the patient doesn't have disease. It may also mean that it's just not enough DNA in the circulation to pick it up. And I think that was my last slide. So in conclusion, we did talk about, this is a new era of discoveries for lower GI cancers. There's a lot of novel approaches and novel ways that we are doing that we are investigating. I think sequencing of available options, personalizing treatment, that is the new era. We have a lot of work to do in appendix cancers to get there, but I think a lot of efforts are in place for that. And this is my last slide. I want to thank all of our patients, our families, my colleagues, all the investigators and the organizing committee for their continued effort in improving research and improving outcomes for this important disease for our patients.